ALCYONE trial, which has already been presented and published in New England Journal of Medicine, has shown for the first time that quadruplet with daratumumab in newly diagnosed myeloma is better than triplet, and the triplet was VMP. The VMP regimen has proteasome inhibitor, V is bortezomib, and traditional melphalan prednisone as one of the standards triplets used mostly in Europe and outside of United States. So to us in United States it was maybe less appealing study, but showed as proof of principle that by adding daratumumab to VMP, we significantly improve progression-free survival across all the categories of patients, including high-risk patients. And that improvement was so significant that brought activity of this regimen with daratumumab to one of the best regimens without daratumumab. So that led to approval of this combination in the United States and in other regulatory environments. And we are now at this meeting showing several of important updates, which in short are very much confirmatory, showing that patients on VMP and daratumumab are doing well and are able to stay in remission for extended period of time. At 3 years, there was over 60% of patients still progression-free. And I would like to say that in a non-transplant group, this is a patient which is elderly and generally most of prior regimen like Lendex or VMP or MPT, which were used typically for these patients, would have progression-free survival in 2 to 3 years range. And we have now already way exceeded this specific number. Now, I would like to add on top of that, because it is eventually going to be an important context, that there is a late-breaking abstract which will be presented at Tuesday morning session. So I am ahead of this presentation, and so I cannot go into specific details of the study, but we know that the study is positive, and this is a MAIA study of RD, lenalidomide dexamethasone, plus minus daratumumab. It's positive in favor of daratumumab. It's a very similar study design to Pollux trial in relapsed disease, which was also very positive. We anticipate that improvement will be at least in the same range as we have seen in Pollux study, and potentially very much anticipated improvement of progression-free survival to the range that there is a good probability, I would predict, that RD-DARA may emerge as one of the top, if not top regimens, definitely for patients which are not transplant candidates. Of course, it needs first seeing the data, which I am anticipating will go along this prediction, and also regulatory decisions about approving of this regimen. But I think as soon as it is approved, I'm hearing from many of my colleagues and patients there is a great anticipation of this particular regimen. I would like to add that field in a newly diagnosed patients will be very much more crowded immediately after RD-DARA anticipated approval, with VMP and DARA already approved in Europe, which we'll have to wait and see how it will play out over there. In the United States, we are already frequently using VRD and KRD, which, by the way, on this meeting shows superior outcome than VRD. So KRD-based regimens are potentially also going into the mix of those type of future treatments options.